okay to present your slides? I think you might have your screen share.
I'll just get that out. I'll have to wait for the current one to stop. Right, okay. Yes. Can everyone see this?
Yeah, thank you.
Okay. Hi, I'm Narut Pakunwanich, and I'm doing the talk about mental health and or learning disability care, managing obesity in the face of adverse social inequities. So the overview of the presentation. So I'll talk a little bit about me very briefly, and then I will do the problem that we're going to face, that we're facing with obesity, outlining a few of the complexities, especially in the context of mental health and learning disabilities, and then also have a bit of a discussion on the research methodology we're using, dissemination plan, and since we've actually done most of the data analysis now, I'll just chip in a few of those things just at the end. A little bit about me. So I'm entering my 4th year of medical school at Lancaster University next week. And my previous research activities have been in multiple regression in obesity in Southeast Asian populations. But I've also done literature reviews in sociology and ethics and stuff like that before, generally around the topic of intellectual disability, mental health, and also sort of ethics about whether we should feed or not to feed people with dementia. In terms of force feeding. So the thing that really strikes me about food is the fact that food is really an experience, a human experience, and it is a reflection of human society. And therefore it reflects all the greater and wider social determinants. And so we have very important trends in history, actually, of food. As our societies have changed, so did our food. So at the very beginning, we were hunter-gatherers. You know, we found things on the floor, we hunted things. But then, came the development of cooking that meat. Actually, before that came fermentation, then came cooking, then came farming. And what we found is, and then after farming, we started artificial selection of, animals and plants. And then after that, we had the Industrial Revolution with industry and refinement of food. And so our food has changed drastically. And the image I'm showing you right now is actually the height of people before sort of in the Paleolithic, so before farming. And we see that people before then were about 179, 180 centimeters. And then with the advent of farming, we actually see the height decrease. And it wasn't until in the Industrial Revolution when our height actually began to return. So that's what that graph shows. And the reason for this is obviously because of without hunting, the diet has drastically changed. And so our diversity in that diet has decreased. And this is a trend that has been going on and still is going on today. And so the 4 trends I really want to highlight is the fact that we have more macronutrients. So macronutrients are your carbohydrates, fats, and proteins. These are things you need lots of, hence the word macro, a lot. And we've been selecting animals and refining food to increase the number of macronutrients so we can increase the number of calories. But that comes at an expense. The expense of which is decreasing concentrations of micronutrients. These are your vitamins. You won't have many vitamins in fish. Not in fish, chips. You won't have a lot of micronutrients in fish. Micronutrients are vitamins and minerals. We also have fiber. And fiber has also been decreasing because if you think about it, if you're trying to make something have more protein and more calories, more carbs, more fat, chips is the great example. You're not going to really have a lot of fiber. And we also have the rise of the dietary carbohydrates because before when we were hunter-gatherers, we didn't really have that much carb in the diet. So this is also another big change. And especially right now, we've got a really big problem with refined carbohydrates when they take all the fiber and everything out and you're just left with your simple carbohydrates. And this is actually compounded worse by, fructose or sucrose, which is sugar. So this is a bit of the historical setting, just to highlight the importance of the trend. So what is obesity? We've heard it in the news, we've heard it everywhere, but what does it actually mean? Okay, we've probably got some ideas already, but obesity is excess adiposity. So adipos is from Latin, meaning fat. So excess adiposity, a bit too much fat, to the point where it's actually harmful to human health. So that is the notion of obesity. And therefore, it must be distinguished from simply overweight. Because overweight just means they weigh more than you would expect for someone of that height. And so how do we distinguish? Now, some of the people in the audience may start to think, BMI. Well, the thing about BMI, and with its nice, simple cutoff, is that life is never that simple. And there are many problems. Well, firstly, there is no relationship between height squared and body weight. There isn't. That was just made to sort of understand sort of surface area, but there is actually no biological sort of link there. So that's one big criticism. The other, and actually more important criticism, is it doesn't, as I said, distinguish what that weight is. It doesn't tell you if it's muscle, or if it's bone, or if it's water, or if it's fat. It doesn't tell you that. And that's really concerning. The other part, of course, is it doesn't tell you where that fat is. So fat, say, in the arms, in the legs, that's actually quite protective, actually. But fat in the viscera, so that's organs, so organ fat and also abdominal fat, that predisposes you to all those heart diseases, strokes, etc. So it's really important to really distinguish where it is. And for that reason, BMI isn't the gold standard, but it's often the most routine thing that clinicians can do. Be it dietitians, nurses, or doctors, it's really the go-to thing. But the gold standard, at least clinically, is the DEXA scan, the dual energy absorptiometry scan, X-ray scan. And that sort of shows you where the fat is and how much of there it is. And that's why it's the clinical gold standard. The other one, which actually makes it a bit more confusing, is blood biomarkers, which can indicate clinical risk. But the thing is that there is a movement going on saying that weight doesn't necessarily, being overweight and having a lot of fat doesn't necessarily mean you have to be unhealthy. And that's usually proponents of physical activity. So, it really is quite a complicated area. But for now, just sort of understand that it's excess weight to the point of harming health. It's also more complicated in terms of different ethnicities because Black, Asian, and minority ethnic groups actually tend to be more at risk, just genetically speaking already. And so genotypically, that's a bit concerning as well as to where we draw the line, especially if it's just BMI. Now, I want to also highlight that health impact is not just a result of the adiposity. Okay, so it's not always just about they have too much fat and that's causing everything. It's also the food itself, because we are what we eat. So if we take a look, this is an excellent example. So fructose. Fructose is a molecule, and it is the molecule found in fruit. And that's where it gets its name, actually, fructus, from Latin, fruit. But it's not really the sugar in fruit I'm concerned of. It's more about the table sugar, the white or the brown sugar that you put in tea and cakes. This is called sucrose, and this is one molecule of glucose with a molecule of fructose. And the molecule of glucose is, that's fine. We need glucose. But the molecule of fructose, on the other hand, is what does the damage. And fructose is more liver toxic than alcohol, actually. And the formal way of saying it is hepatotoxic, because hepatos in Greek means liver. So hepatotoxic, it's more hepatotoxic than alcohol. And because of this, the liver turns it directly into fat. And so it is, a big cause of weight gain. But there's something more important than that, because in the process, its toxicity, being more toxic than alcohol to the liver, it actually does also damage the liver. And that's how we get non-alcoholic fatty liver disease. And in actually most developed nations, most people have sort of a degree of liver damage already from all the added sugar in our diet. And this is obviously all because of the big obesogenic environment. There's barely anything these days that you can buy without added sugar. And if it is, it tends to be expensive, and I'll talk about that later. And therefore, you actually get direct consequences because of this, added sugar, regardless of the weight. So this is just one out of many illustrations about why the food itself is also a big impact, not just the weight gain. Now, social exclusion marginalization is actually very important, especially in the UK. And this is because the graph I'm showing you is something called the nutrition transition. So this is looking at obesity in a global perspective. So on the left-hand side, the y-axis, the thing going up, is the level of obesity. And on the x-axis going across our screen, we see the economic development. So in the bottom left, we see the traditional diet. That's in very, still developing economies. And what we see is the red line represents those of high socioeconomic status, and the black line in the graph represents those who are either marginalized or of a lower socioeconomic status. So if we take a look at the very beginning in the developed countries on the left-hand side, it is the rich who can afford the food. And so it is the rich that have levels of overweight and then, are predisposed to obesity. And then, but as we move along the graph towards the right-hand side, we see that actually it changes, because from switching from the traditional diets to the, quite frankly, quite obesogenic Western globalized food, we actually see, like McDonald's and stuff like that, we see that actually it becomes the poor, because the rich, as the country develops, the rich can afford all the, sugar-free foods. They can afford to pay for gym memberships. And it becomes the poor without good health literacy, without good education, and in marginalized conditions, and who can't afford good quality food, and might actually rely on food. Food poverty and food insecurity in these cases are very strongly associated with obesity. And it makes sense. So we can see on the right-hand side, it is those of lower socioeconomic status, those who are marginalized and excluded, who are obese in developed countries. And that's really important, because then obesity acts as a vehicle of oppression. And I think this is sort of a theme that I might weave through this discussion, is that obesity is, in this case, a form of oppression. And this is especially true for people with mental health and or learning disabilities. As I said before, people with of a lower socioeconomic status and poorer health literacy are already predisposed to this. And this is especially true in mental health and or learning disability. They have lower rates of health literacy. They tend to not really be employed. And if they are employed, they tend to be working lower paying jobs. They have, there's a significant health and income disparity, and it's been, shown throughout various confidential inquiries and government reports. And if we're looking at, significantly lower life expectancy, that's no longer, doctors used to think that it's because of their condition itself or the drugs, but actually it's also because of society's impact on their health, access to healthcare, and obviously obesity is one big part of that, because they have amongst, one of the highest obesity rates of any marginalized group. And this can, this oppression and intersectional oppression is often intersected with things such as, being of minority ethnic groups, etc. And so it's a very important sort of thing that we understand obesity as also a big social problem, not as a problem and failure of the individual. They also have reduced support networks and often lack what we would consider a nuclear family, especially people with learning disabilities, because they tend not to be married. And the intimate life domains of people with learning disabilities is a really important area of research that is currently developing. And it's still in its infancy. So let me talk a little bit about the influences between the three components of diet, physical health, and mental health. And actually, we'll be talking about whether these should be considered three different components later. So I've been talking about, diet and its relation with physical health. And I think that's the most obvious thing that people sort of get. They understand that if you're obese, then you're more predisposed to diabetes and other diseases. I think people can sort of understand that. The other two bits, however, aren't as well sort of discussed. So if we start thinking already mental health, so in the context of mental health, people with, say, schizophrenia, who suffer psychotic episodes, who have these psychotic episodes, they are often put on something called atypical antipsychotics. And these new generation drugs are much better than the old ones, but they've got something called an iatrogenic effect. All that means is it's basically a side effect. And these drugs, these mental health drugs, basically predispose this population to cardiometabolic risk alone, without even thinking about obesity. But then more importantly, a lot of them also bind on to histamine receptors that they shouldn't. And this causes a hunger. And therefore, people with mental health and or learning disability will then eat more. And so this is obviously a very clear example of how mental health can influence both physical health and how they interact with their diet. And if we start thinking about mental health and diet, about trauma. Trauma is actually a very important part of this, because in post-traumatic stress disorder, people often develop a bit of a psychological maladaptive sort of coping mechanism. So what they do is they eat, because when they eat, dopamine in the brain goes up. right? And dopamine is rewarding, and that's good, and it comforts them. And for somebody who's gone through, early life abuse, it makes sense as to why this would be a bit comforting. And that's why most research does identify not only the biological basis of this, but also the wider public health epidemiological basis, which is that people who have suffered more severe or more frequent early life trauma and childhood adverse experiences tend to be the ones who have greater weight gain in adulthood and more and higher prevalence of obesity. And that is very well established. Other conditions such as ADHD, attention deficit hyperactivity disorder, or EUPD, emotionally unstable personality disorder, these disorders are characterized by impulsivity. So I don't really want you to be confused by the rest, but just understand that some mental health conditions are characterized by their impulsivity. And in this case, impulsivity is not a very good thing when you're dealing with the diet and weight management, is it? Because they often eat impulsively as well. Now, the diet can also affect the mental health. So, for example, schizophrenia. I've mentioned schizophrenia before. This is when somebody is predisposed to psychotic episodes, and they believe it is because of excess dopamine in the brain. So we can already start to think, well, if eating, and especially highly refined carbohydrates and sucrose and fructose, sugar, that tends to release a lot of dopamine because our ancestors didn't have a lot of carbohydrate in their diet and not this refined, obviously. And so it releases a surge of dopamine. And that does predispose one for further psychotic attacks, but it also predisposes them to use it in a very similar way as to those with PTSD, post-traumatic stress disorder. And so we can already see that it's actually a very complex topic. Now, there's also, the gut, the microbiome. I think a lot of people have heard about this. It's sort of been trending in sort of the news and public discourse. And food obviously does have a very direct impact on the gut and the microbiome, especially because a neurotransmitter called serotonin, which is used in the neurons, is 90% produced in the gut. So you can already think, and actually in the gut's microbiome, the bacteria that make up the flora. And so we can already start to consider, this is a very sort of important thing, that food affects physical and mental health at the same time. There's also, of course, body image, because people who tend to be more obese, obviously, there's a lot of stigmatization now in society around that, which is not at all helpful and often predisposes people to mental health issues later on. And that obviously feeds back into their physical health, because if their mental health state, they're not in the right mental health state, they won't be motivated to be able to manage their weight. And so that doesn't really help anyone at all. And actually, sometimes it makes people want to eat more because they just give up. So this is really important to understand as well. But I will actually challenge the separation of physical and mental health. And this separation began with René Descartes. And René Descartes basically separated the body from the so-called the mind, the psyche. And I'm going to say that actually that's not necessarily true. And actually breaking down the Cartesian dualism divide, and I will talk about this later, is actually one of the key parts that I really want to push out there. Because, the diet affects the mental health, but the way it does that is often through biological means. And mental health, a lot of the reasons that doctors explain why mental health happens is usually because of some neurobiology, some sort of biological component. And of course, the model of mental health that's right now being, there's a chat. All right, thank you. Yes, sorry. And then in terms of mental health, the pathophysiology is often explained in biology. And so, the biopsychosocial model is what's being used right now. It incorporates the biological, the social, and the psychological. So let's re-examine our examples very quickly. Right. So schizophrenia and major depression. So we talked a bit about dopamine, and sugar's effect on dopamine, but actually sugar also suppresses brain-derived neurotrophic factor. And so when they did a study about the sucrose intake of people with schizophrenia and people with depression, unsurprisingly, at the 2-year mark, they found that it was very statistically significant, the amount of sugar they were intaking a day, on their schizophrenia and depression outcomes at 2 years. And this is because brain-derived neurotrophic factor is really important for maintaining neuronal function. And so if sugar suppresses that, it actually causes atrophy of the brain. And actually, this already happens in these populations without sugar. So we can actually see that sugar makes it even worse. That's just another example. In terms of post-traumatic stress disorder, people with these conditions have a very blunted cortisol with excessive catecholamine release. What that basically means is they have chronic stress and then even more stress if a trigger happens. And actually, stress upregulates neuropeptide Y, and neuropeptide Y stores fat around the abdominal organs. It promotes that, the storage of fat. So we can already see that it's not simply three components. It's actually very complex. So perhaps rather than this, we could have this. Physical and mental health are both, important to the overall health, the self, and they aren't actually, truly separate at all. And the diet and the social and wider determinants of health influence that. So a bit about a weight off your mind. So Weight Off Your Mind is a very big project, and it really is aimed towards this group of people. Now, for the project of our research, we're only going to be talking about the NBMI CLIP, and this is the Nutrition and Body Mass Index Person-Centered Clinical Link. Basically, what that means is it's essentially a way of monitoring an inpatient's weight. So this is just the inpatient setting. So it's just a small component of a Weight Off Your Mind. And so what it does is it monitors people's weights and any weight changes, and then tries to sort of help them and empower them take control of their weight. And it replaces something called the MUST, the Malnutrition Universal Screening Tool, with the SANSI, the St. Andrews Nutritional Screening Instrument. The reason for this is because the MUST only, basically it only warns you, you only get into sort of the serious category, serious concern category, if you are starving or, are at risk of being underweight. But the SANSI does underweight, overweight, sort of extremely obese. It also does weight changes as well. And so that's why it's much better. And actually, in the results of our staff survey that we sent out, the SANSI was identified by the majority of staff members as being the most useful tool. So that's already a really a good thing. So this research project is essentially assessing staff use and staff engagement in the inpatient settings using this NBMI CLIP. So firstly, we had this pilot survey, which goes out, and then it will be followed by a main survey, which is part of someone else's doctorate. I'm just sort of doing the pilot survey. And the pilot survey is broken into three main parts: how the staff are interacting with the patients and what's influencing the delivery of the NBMI CLIP. The second part is about staff reflecting on how they want to be supported with their own weight management. And then the third part is about the pilot survey. But overall, people have found the pilot survey very good. And so it will most likely be very similar in the main survey. In terms of the mixed methods data analysis plan, essentially we're going to be doing quantitative analysis of all the ordinal data, all the numerical data, basically all the multiple choice sort of questions. And then we have done actually thematic analysis and all the free text responses of the staff. So the dissemination plan. So we're going to do a full report, including a 3,000-word literature review. There's going to be an internship report back to the funding body. As my colleague has mentioned before, there's going to be a FUSE blog, individual and combined, a potential FUSE briefing for future policy makers, and then also an editorial and commentary piece about COVID-19 and the effect it's having on the weight of people with serious mental illnesses. There is one thing I wanted to talk about before leaving. The thing that struck me the most is that a lot of staff talked about the lack of user engagement, that people weren't really engaging in sort of the NBMI CLIP. They refused to be weighed, and they didn't really consent a lot of the time. They didn't understand the need for it. And so this was really informative. And also the other challenges that we found was the fact that the obesogenic environment pervades into the staff. Into the wards where the staff are working. So, for example, fast food and takeaway outlets, patients can often get that delivered to them, an excessive amount actually. And it brings up the question of whether this is good for them, and therefore, what really is autonomy? So, autonomy, when we think of it in the healthcare ethics sort of thinking, we're thinking autos is Greek for self and nomos for law, so self-rule. And a lot of the time this means just acquiescing, just bowing down to whatever the patient wants. That's respecting someone's autonomy. And perhaps that is true, but I do not believe, and actually there is a big sort of literature around this, that autonomy is that simple. because autonomy really is a spectrum. And actually, I would argue that the purpose of healthcare is to create autonomy for people. That illnesses take away autonomy, and us as healthcare practitioners and clinicians must sort of create the autonomy back for them. But there is something called the autonomy flip, and this is really interesting and has been sort of proposed and talked around in sort of the healthcare ethics community. And that is, at what point does creating autonomy and respecting autonomy, which one should be prioritized? So clearly, if their autonomy is low, they don't really have the understanding to really, understand the impact of their decisions. So, for example, a delirious patient, they'd be quite low. And so we would treat them, until their physical and mental health condition improved to the point where it surpasses the flip, where at that point, okay, right, they have informed decision, they have the capacity, and really, they really know what these consequences are. And so at that point, we should respect their autonomy. And this has been, widely discussed. And the problem, of course, is the current legal system doesn't really allow for physical conditions that aren't related to the mental health condition. Once again, the Cartesian dualism divide. It doesn't really allow for those, quote unquote, unrelated physical conditions to be managed without consent. And so this is a really big part of understanding and thinking about what it means for patient. And the other part, of course, is that nutrition and food has really been separated from health. And this is quite interesting because in the modern sort of public perspective, people think about diet and exercise and food as, things quite important to healthcare. But in the hospital settings, we've got, feedback from some nurses and whatnot saying that isn't this sort of the dietitian's job? And this is sort of quite a problem if you're going to separate it. And I would argue that actually it all needs to be intertwined together. And so I'd like to leave you on one final point, which is that managing weight and obesity is actually everybody's business. So thank you for listening.
Great. Thanks, Narut. That was excellent. So we do have Narut and Mariam for questions. I don't know if you can turn your screen back on, Mariam, just so everyone can see your responses.